Touchpoints here, paving the way.
Women in the health sector face the worst pay gap across different development sectors. So if you're a woman working in the health workforce, you're actually at the lower end of the health workforce. You're really on a type of subsistence. Community health workers are paid a stipend.
You might see that, as you're putting policies in place that are actually really effective, you might actually see an increase in the reporting of violence. And it's sort of something that we need to be thinking about. So it's not just reducing the violence numbers as we're measuring them, because you might actually see that if you have a really effective policy where you didn't have an effective policy, that people feel safe in coming to report some of the violence that has been already occurring.
Good morning, good afternoon, good evening, everyone, and welcome to PMNCH Touchpoint, a podcast where we touch base with experts in the field affecting women, children, and adolescents' health to bring you insights and solutions to the problems you face in reducing maternal, newborn, and child mortality. Gender-based violence has a profound impact on maternal, newborn, and child health, including increasing the risk of prematurity and low birth weight in babies, and in causing delays in access to antenatal care and skilled birth attendants. Women who suffer from violence are less likely to breastfeed, follow postnatal care, or provide adequate nutrition and immunization for their child, perpetuating a cycle for poor health outcome. The focus of our discussion today is a critical but often overlooked dimension of this topic, which is violence against women in health workforce. Today, we take a different angle. We look at women in health workforce and how the violence they experience compromises their ability to provide health services. Health workers are at the heart of any healthcare system, especially in the provision of primary healthcare services. When female healthcare workers, who make up often the majority of this workforce, experience violence, it does not only harm their well-being, but also jeopardizes the quality and accessibility of care. This has far-reaching consequences, particularly in reducing maternal, newborn, and child mortality. We are privileged today to be joined by Dr. Asha George, a leading researcher in global health, who authored the seminal BMJ paper, Violence Against Female Healthcare Workers is the Tip of the Iceberg of Gender and Power Imbalances, and Dr. Michelle Makisek, an economist in the World Health Organization Health Workforce Department, specializing in gender. Together, we will discuss the scale of this issue, its root causes, and how we can move forward towards a meaningful change. Through this conversation, we hope to shed light on this pressing issue and inspire collective action to create safer, more equitable workplace for women in health. But first, let's get the stage ready for today's discussion by exploring why this topic matters. And maybe, Asha, I can start with you first. And to start by looking at trying to understand the magnitude of the problem. We know women make up roughly 70% of the health workforce. How many women are experiencing violence? What are the most visible or invisible forms of violence that women face in health workforce? And how do they manifest themselves differently across the different regions? Over to you, Asha. You're on mute, Asha.
Yes. Thank you so much, Rajat. I'm so delighted to be with you and Michelle, who's a real powerhouse in terms of gender data, supporting policy change in this area. I think a key thing to understand is that we have yet to fully understand the magnitude of this problem because the experience is so normalized. There's very inadequate reporting, and even our response mechanisms to address the problem are very weak. Just as the evidence, it took 30 years to build the evidence at a population level on violence against women, we're in the health sector just beginning to recognize that we have a problem and that we need to learn from others who've been doing research of this kind to measure more adequately the extent of the problem. It's striking that in 2019, there was a systematic review that showed that 61% of health workers had some form of workplace violence. And I'm really delighted WHO is updating that work. So next year, we should have updated estimates. And it's striking that there's the range of violence varies. You know, we're still learning to categorize the different forms of violence. But in terms of direct experience of violence, 42% involved non-physical violence. And that's the kind of violence that women tend to report more than men. And 24% involved physical violence. I'm just going to report two other studies. Last year, there was a survey that collected data from nurses and physicians from 79 countries, and they reported that women, there was more females reporting emotional violence and sexual violence, and it was really men that had reported higher levels of physical violence. That's women and men, but actually there's further understanding that it's really those who are at a younger age, less experience, who have informal contracts, less professional status in the organizational hierarchy, minority groups that actually have further disadvantage once we get beyond the gender binary. So the data is we don't have studies that report this consistently, but the emerging evidence from the scoping review last year is beginning to show the magnitude, and I hope the push to do a better job in measuring the magnitude. Thank you.
Thanks for that, Asha, and laying out the magnitude of the problem, but also the complexity of the pathways through which it manifests itself. But also importantly, as you talked about, is the differentiated impact it has on subpopulation groups and how it manifests itself. Michelle, coming to you, we obviously know that violence in and of itself is a baffling of human rights. But we also know it has many other consequences. And in terms of economic and professional consequences, what are some of the ripple effects of this violence for health systems and for communities that these health workers serve? And could you share any data trends that can help us understand the scale and the scope of problem that we are talking about? Over to you, Michelle.
Thanks, Rajat, and thanks, Asha, for laying out some of the trends in the data that we know. I think a lot of what we've seen published thus far is looking at trends pre-COVID-19, and I think it's really important that WHO has taken this step to update these figures to really understand what's happening in this kind of post-COVID-19 pandemic world, because we've heard a lot of at least anecdotal evidence that there's been an uptick in violence against health and care workers. It could just be that the spotlight is more on it and the trend is fairly flat. But there's also a potential that there's been more tension in health workplaces as well. And on the other question around the economic implications and sort of these spillover or run-on effects, I think from an economic standpoint, it's important to think that the consequences of violence are really, really profound, right? So the consequences of violence don't just impact the health worker to which the violence is perpetrated, but they have these really profound impacts. So the first impact that I wanted to highlight is that there's a direct cost. So the cost of the care or the health services that are attributable to the violence. So usually if someone receives violence in the workplace, they then need health and care services themselves. And then there's the impact on lost work hours of those workers, right? It could impact their motivation. It could impact the motivation of their peers. And the more insidious effect is this longer term impact on the health workforce. So where violence occurs, where safety is a concern, we always expect to see things like high turnover rates, absenteeism, burnout among health workers. And so we're already in a global environment where shortages of health workers are putting a squeeze on the existing health workforce that's there, and unsafe environments can really exacerbate shortages. Attrition of health workers, reduced productivity in the health systems, but there's also an impact on the kind of overall attractivity of any occupation that safety is a concern. So this is especially concerning in health systems where this kind of ripple effect that you alluded to of violence can reduce the overall capacity of health systems to provide care. This could also actualize intangible negatives, such as kind of longer term, like in health systems, such as wait times, negatively impact health outcomes when health systems are not performing at their full capacity. So if these kind of health impacts that I've highlighted are not enough concern, the negative impacts don't stop at the borders of health systems. So there's broader suffering in the economy that happens as well. So we know that violence-related injuries can have a downward impact on GDP. And so if this violence is perpetrated towards health workers, the spillover effect is not just that the health systems, which of course impacts GDP, become less productive, but that if there's longer wait times in the system, this impacts the productivity of the entire economy, right? So we're seeing a spillover effect that's impacting the productivity and the output of all the sectors, not just the health sector.
Thanks for that, Michelle. And actually, elaborating very effectively is both the point about that the violence against health workers does not happen in an isolation and the ripple effects that it creates, but also the direct and indirect effects that both the health system and societies overall tend to bear when the violence occurs. And Asha, that nicely, brings us back to you and to the paper that you wrote in the British Medical Journal. And the paper is captioned as the tip of the iceberg. And I wanted to ask you, could you elaborate further, and hearing what you just heard from Michelle as well, is what lies beneath the iceberg and what are some of the hidden layers of gender power imbalances that make women in healthcare particularly vulnerable? Over to you, Asha.
Thank you, Rajat. I think we felt very strongly that violence happens in a social context. Health workers work in society, belong to the society, as well as serve society. And therefore, we need to understand that social context better. And so just as it's important to recognize and measure acts of violence and respond to those very direct forms of violence to protect our health workforce, it happens in a broader social context. And we used a feminist lens to look systematically at how certain types of health workers, and particularly women, female health workers, are disadvantaged, that make them more vulnerable, but also less able to stand up for themselves, to report violence and work collectively to develop solutions to address violence. So it's a framework that's been part of feminist analysis for a long time. Srilata Batliwala did a paper on gender power. We've included it in gender analysis. And let me break it down. It's really 5 points. The first one we've talked about, what is known. You can't address a problem if it's hidden. And that's the first thing about patriarchal ideology, is that it normalizes experiences so that you don't see the problem. So we need to do a lot more to make the problem visible, address the underreporting, and understand more clearly the contextual issues and dimensions of the problem. The second is making sure who has what. What are the resources that enable better reporting? What does safety look like once we take this gender lens and apply it to the health workforce and look at actually developing safety measures that respond to those who work across the layers of the health system? A lot of our safety measures are biased. Even in COVID-19, PPE, who had access to PPE, there was a hierarchy, and that hierarchy is gendered. Even how we think about safety, community health workers often, facility-based health workers, there might be a guard, or you're in a facility with other colleagues. Community health workers that are often women, they're out in the community. They can't fall back on their team members. So we really need to rethink what kind of resources, what does safety look like for across the health workforce? The third thing is who does what and how are they rewarded? And I think Michelle at WHO has really highlighted that women in the health sector face the worst pay gap across different development sectors. So if you're a woman working in the health workforce, you're actually at the lower end of the health workforce, you're really on a type of subsistence. Community health workers are paid a stipend. So do you really have, are you empowered to take on the system? You're not. You're really, already at a marginalized starting point. And that leads to my two other points: who is valued and who decides. We have a health system where hierarchy, occupational hierarchy, has baked in gender discrimination. I'm not using very romantic, there's no romanticism. There's, we need to really come face to face that these hierarchies, the way in which nursing has evolved, medicine has evolved, there are many ways in which gender ideology has put women at a disadvantage in the health sector. And how we respond to women in leadership is part of that. There are certain biases in terms of how we look at women leaders, if they even get into a leadership position in the health sector. So let me pause there. There's probably many more. That's a lot to give back on. But I think if we recognize these systemic ways in which gender hierarchy plays out, we can develop systemic solutions and go beyond. We need to address the violence, but we need to also understand the systemic issues that put certain individuals at a disadvantage. And without that, we'll just be responding to the violence that occurs, but never really address how do we create a stronger health system where the health workers can really respond to extremely challenging work contexts already. Thank you.
Absolutely. And thank you, Radha Asha. Very telling, and the way you outlined the deep entrenched systemic power imbalances that tend to define health workforce and health systems, and the kind of layers of vulnerability it tends to create for women as health workers is rather profound. Before I come to Michelle in a moment, I did have a brief follow-up for you. And in the sense of, do you see any, regional or cultural variances in the way the systems of power tend to manifest themselves, and does that make certain regions or cultures more vulnerable to violence against women healthcare workers?
I think there are certain contexts where violence is more pervasive. For instance, in context of conflict, you already have armed conflict happening, and that filters into what's happening in health facilities here in South Africa, and not just in South Africa, but in many contexts where you have structural inequality. We have communities that, because of poverty, there's lack of employment, you have organized crime, communities face violence on a day-to-day basis. And therefore, that's an additional layer to the violence that's faced by health workers. So there's context in terms of conflict, and conflict doesn't have to be between armed, I don't know what the national armed groups. It can be neighborhood armed groups. And that's an additional layer. But the other contextual driver that I think there was one study that began to look at was when you have health services that are under-resourced, that are already operating under strain, the expectations are not met by the patients who are coming to health services. There is a higher level of frustration. There's also less resilience from health workers themselves. They're coping with very difficult work environments, and the vulnerability to violence is much higher. So for me, it's not geographic, like, the Americas or, Middle East or South Asia that is more or less prone to gendered violence in the health sector, I think we have to break it down to much more these contexts that could happen in any region in the world, but our contexts of structural inequality and conflict, and what additional measures we need to think about in those contexts. Thank you.
Thanks, Asha. And that's actually a nice pivot back to you, Michelle. If we do look at it from a slightly different perspective, do you see variances on these issues between high and low income countries as such? And if I could add another layer to it, are there drivers that you think, in the sense that make these issues more susceptible, for instance, funding shortages or staff shortages that create the kind of scenarios that I think Asha was starting to touch upon towards the later part of her response? Over to you, Michelle.
Yeah, so I think, thanks, Asha, for answering much of that question. I think what we do understand is that in settings where resources are low and there's a lot of existing challenges that are there, and so needs are not necessarily being met, that this could exacerbate problems, right? And this is true for any income setting, right? I think when you're having challenges with staff shortages, with higher pressures, with things going quicker, this can exacerbate different forms of violence, right? That sort of Asha highlighted earlier. But I think it's a little bit challenging to provide kind of a definitive answer to the question, because I think that much of the sort of this high income, low income question that you asked is much of the research is happening in high income countries, right? So particularly regarding the impact of violence on health workers, a lot of the data that we're getting is conducted from high income countries. So it's hard to say what the difference is if we know a lot in one setting and less in another setting. But I think what else is important to think about is it's not just the income setting that we're seeing differences in data and differences. It's also the settings that are considered kind of high risk for workplace violence and harassment, such as psychiatric wards, emergency departments, long-term care facilities. We're having more evidence in these situations, but a lot less evidence on the community and the primary care, and certainly in the space of women, children, and adolescent health, where much of this is happening in these spaces of primary care. We're not seeing the evidence coming out, so it's difficult for us to say how this is being played out. I mean, it's kind of a non-answer, because essentially there's so many evidence gaps that we need to plug in this area. And as Asha said, when it's an issue that becomes sort of normalized or expected, you know, it maybe isn't studied as well as it should, and maybe it's not reported as much as it should be. So we're understanding less about an issue than we should. But yeah, certainly issues such as staff shortages, funding constraints, these can exacerbate certainly risks of some forms of violence. Particularly those between patients and health providers, but there's systemic issues that I think, that Asha pointed to that are also really overlooked sort of in the gender inequality and hierarchy space in health and care workplaces, where these kind of hierarchies are so deeply embedded, and that these inequalities that come from these power imbalances between those at the higher end of the hierarchy and those at the lower end of the hierarchy can contribute to the risk of workplace violence. And some of the work that we've done with the ILO and with others, it really shows that in the health and care sectors, there's a really high number of very low paid workers, and that are, that's different in this sector than you might see in other sectors. So, where we see average wages being lower in this sector, it's often driven by this really high number of really low paid workers. And the fact is that many of those really low paid workers, a vast majority of those really low paid workers are women, and often women from different and more marginalized backgrounds.
Right. Michelle, do you think there are certain professional categories that are more susceptible to violence? Nurses, midwives, or those, for that matter, providing certain kind of healthcare services, whether it is antenatal care, safe abortion, etc.?
Yeah, so there's some evidence to suggest that those kind of health workforce roles that are more patient facing, maybe those that are in different settings, such as the community, where there isn't the sort of security that might be in a more facility, might have a higher risk of violence. There's also, as I said, some evidence to suggest that settings like psychiatric wards and emergency departments where there's that tension, right? Often the time, quickness that happens in those spaces that create an environment in which violence might come to the surface more. So nurses and doctors in patient-facing roles, community health workers who are out in the communities, often alone, might be at higher risk. But I think it's also important to point out, as I think Asha did before, that there are many different forms of violence that occur. So there's the verbal abuse, sexual harassment, physical violence, and that different occupations, of course, but also different genders, different backgrounds, different ethnicities, they are all going to be facing different risks that goes beyond even occupation, that goes beyond even a workplace setting. And I think it's really important to understand, the intersection of all of this as violence is coming to the fore and as we're studying it more and more.
Absolutely. And then the deep and pervasive nature and how it manifests itself across the different cadre of healthcare workers. Asha, you've already alluded to some of this, and your remarkable paper goes into much detail. But the metaphor that you use in terms of the tip of the iceberg, insinuates that there are deep root causes, entrenched biases, issues in terms of undervaluation of caregiving, and lack of representational leadership that you spoke about. How do you see these issues perpetuate the problem that we are talking about? The biases, the deep discrimination that we have been talking about. But also, how do you see them intersect with other issues, such as race, socioeconomic status, etc.?
Thank you, Rajat. I think one thing that I'm blown away working in the health sector is the complexity of the health sector. And there are certain ways in which we operate that hide who are the people that we're trying to help. So we have categories like community health workers, nurses. In some contexts, we might assume that nurses are female, but in some contexts and countries, nurses could be primarily male. Even community health workers sounds like a homogenous term, but it's not at all. Some of them are paid, some of them are semi-paid, some have training, not training. And then these categories, we don't know the race, gender, many marital status, age, all of these factors, who are the people behind the categories? It's almost hidden in the way we talk about our health sector. And there's very few studies that are beginning to unravel who are the people involved and what are their lived experiences. And I think that can help us these categories are very important, but begin to really understand how deep some of these forms of discrimination run in the health sector. And I think there was a study it was around the time of COVID-19 in Brazil that did a survey that ranged from community health workers to, I believe, surgeons. And they broke it down in terms of race and gender. And you began to see they had qualitative as well as self-reporting. It was a self-reported digital survey, but they also had qualitative data. And that sort of delving into the complexity of who are the people and not being overwhelmed by the complexity, but allowing that to ground your responses is what we need. Because as much as we need the advocacy points of the slogans, the simple bullet points to push policy, in terms of developing local solutions, we need to break it down to who are the people we're talking about in each context. What does community health workers look like? And what are their experiences? And perhaps most importantly, what are their perspectives? I think it's a sector that's incredibly paternalistic. And the policy measures that are developed, health workers themselves at the lower level don't always have a voice. And I think it's these ways in which an intersectional feminist analysis to the problem brings out the people, but also tries to bring out their voices so that their perspectives inform the policy measures that are developed. And that will have much more lasting impact because it has relevance to their work environment.
Indeed. And thank you for laying that out, Asha. Michelle, are there some evidence in terms of fixes within the health system in terms of addressing the inequalities, such as equal pay initiative that has helped reduce violence against health workers?
Yeah, so I think before I answer specifically, I wanted to point out that there's a couple of really good references in this area that are really helpful for us. We don't have as much in the sort of sector-specific zone, but I think that there's references from other places that we can, and I have one health sector-specific one. So I think one of the really good references that we need to think about when we're looking at examples of effective policies or what can be done is the ILO Convention 190, which is the Workplace Convention Against Violence. So it envisions a world of work that's free of violence. It's not sector specific, but there are elements in that are really important for the health and care sector to think about, which is protection from workplace violence, regardless of the setting, regardless of the contractual status. It covers volunteers as well, which is very relevant to our sector. And 45 countries have already ratified this particular convention. So it's one of the ones that WHO really puts a lot of weight behind as something that can really drive change in the sector. We also at WHO have developed something called the Care Compact. So it's the Health and Care Worker, it's a Care Compact, and it outlines 10 policy actions specific for protecting health workers against violence and harassment in the workplace. And then there's also the Respect Framework, right, which is specific to violence against women. But there are many of the elements in the Respect Framework that would be really very relevant if you're outlining policies, particularly the empowerment of women, relationship skill strengthening, transforming attitudes and beliefs, that services are ensured. You know, there are many of these elements that are very effective. So specific to your question, what have we seen in the data and the evidence? So there are really promising examples of interventions that reduce tackling these inequalities that have been studied specifically in health and care settings. Some, focus more on prevention, some on protection, some on de-escalation, and finally some that are looking at actually treating the violence that has occurred and how we do better at that. I think a lot of the evidence that we've seen coming through the pipeline is really on education and training programs. So these are ones that are looking at improving staff knowledge and skills and managing workplace violence. And these are kind of often part of like a broader organizational intervention approach. And they can really kind of help raise awareness and, provide tools for de-escalating these situations, and might have an impact on kind of reducing the overall incidence of violence. But I think one of the things that we have been talking a lot about in this particular podcast is kind of the pervasive structural issues that aren't addressed by these particular kinds of programs, right? So addressing those underlying inequalities are really important. Equal pay initiatives and leadership programs for women are certainly ways that we can start to think about changing, some of the systemic inequalities that we observe in this sector. And then, creating more supportive and equitable work environments in a more general way. They also can show some promise, but we don't see them as well studied. And we haven't seen particularly the studies that are looking at drawing these to the workplace violence in the area. So there's certainly a lot more that needs to be done. But I think, one of the things I think it's been sort of brought out a little bit in the podcast, but I think it's really important that we say it again if it hasn't been, is that, studying workplace violence is actually really tricky because of so many barriers in reporting. And, with some of these kind of imbalances and powers that we've discussed, you might see that, as you're putting policies in place that are actually really effective, you might actually see an increase in the reporting of violence. And it's sort of something that we need to be thinking about. So it's not just reducing the violence numbers as we're measuring them, because you might actually see that if you have a really effective policy where you didn't have an effective policy, that people feel safe in coming to report some of the violence that has been already occurring, because that's sort of the nature of this type of work. So I think it's really important to be taking these holistic reports and looking at the violence differently than just kind of measuring and monitoring how many reports we've had.
Thank you. Thank you for that, Michelle. And as we come to the end of our conversation today, I do want to come back to both of you. And you know, Asha, first to you. We've talked a lot about, you know, the metaphor of an iceberg, the root causes that need to be addressed, the kind of deep entrenched systems of power and power imbalances that tend to, you know, facilitate and inform the kind of patterns of violence that we are talking about. Any reflections from you on what are some of the successful strategies to shift power and address these issues that you will want to recommend to our audiences, to governments, policymakers that can effect meaningful change?
Thank you, Rajat. I have two reflections. One, it's exciting that this issue is getting more recognition. And sometimes it takes very painful events, as the rape and murder of the doctor in West Bengal just a couple of earlier this year, to remind us of how urgent and critical this issue is and how neglected it is. I think part of the challenge, it's great that we're getting more recognition, but part of patriarchy is the cosmetic changes that happen once there is recognition. And I think one thing we need to accept is, or really be cautious about, is the rhetoric around women's leadership. I think women's leadership is absolutely vital, but we need to go beyond simplistic measures that place the onus on women to change the system. We need, you know, a much more engaged review of what are, as Michelle said, the systemic issues that are undermining this, and just promoting. There's so much investment, which is key, and yet the systems, when I look at in global health, even in the who's there at the UN in New York or in any global meetings, it's mostly men at the table, and yet all we can talk about is women's leadership. We need to talk also about who's actually in power and who's making decisions for whom, and really get some engaged systems of monitoring, engagement, and accountability so that women's leadership has effect and is not just a cosmetic response. So that's my first point. The second point is that there is such an opportunity for change, but it has to be done in partnership. It's not going to be anyone, you know, we need the professional associations engaged, health managers, and we need researchers working together. And if we have those type of partnerships, we can open windows for change rather than thinking that one actor on their own or one policy measure is going to leverage change. The complexity of the issue and the need for context-specific, you know, health system-specific responses mean that we need to work collaboratively to address that complexity and develop solutions that really have impact. Thank you.
Thank you, Asha. Michelle, what can organizations such as yours, the World Health Organization, do to help countries address these issues on the ground?
Yeah, so I think there's a lot that organizations such as all of the UN family can do, and WHO in particular can do. I think there's a lot that can be done from the levers of things like leadership, right? So having the discussions, having a podcast like this, making sure that there's some communication and knowledge sharing and leadership, making sure that this is coming through. I think also in terms of norms and standards, which is a function of the WHO, that's really important for us to do. And you can see this coming through in our organization, but in others such as you know, norms and standards in terms of the ILO Convention 190, which can be adopted, in terms of the policy actions listed in the CARE Compact, in terms of the frameworks that we've developed, such as the RESPECT framework. I think the data and monitoring one is one that we'll be seeing probably some new evidence coming in 2025, but more regularly monitoring the situation so that we could actually understand impacts such as the COVID-19 in more real time would be really important for us to do. And I think, as Asha alluded to, we also play a really important role in convening So bringing together the different stakeholders in this space, ensuring that they have voice, but also the different sectors in this space that are important in terms of addressing some of these issues, I think is very important. I think the other thing that's really important to point out in what organizations such as WHO, but any organization, not necessarily even international organizations, need to be doing is gender mainstreaming. So I think taking the violence issue and looking at it and studying it in isolation will give you an understanding of maybe a better understanding of that problem, but it won't give you an understanding of the systemic issues that are driving that problem. And so I think the concept of gender mainstreaming, which we hear talked a lot about, is actually a really important one through health and care workforce policies. It's a really important one in also health systems, looking at all of the various components of that: financing, workforce, service delivery, and others. I think so. This gender mainstreaming component of this would better help us to understand where the parts of the system are not helping, diverse genders as well.
Thank you. Thank you so much, Michelle. Thank you, Asha, for this really eye-opening conversation. And you raised, the veracity of issues that one needs to take a deep look and introspect about. But, some key takeaways that came from our conversation, and very rightly put, that there aren't any silver bullets that we are chasing. There are no easy fixes. What we do need to do is to invest in women's leadership, not cosmetic changes that will not help us achieve the kind of systemic change that we want to achieve, but investing in initiatives such as those related to gender mainstreaming, to those in terms of that help build the partnership across different disciplines and sectors to address the complexity of issues that we are trying to address in this regard. I'm sure we could have continued talking for much longer, but before we do conclude, I do want to come back to each of you for any final parting thoughts, any last recommendations or reflections that you would have to share with our listeners, and then we will conclude this episode of Touchpoint. Asha, first to you. Any quick reflection?
Thank you. I wanted to stress, there hasn't been enough work, the evidence at community and primary healthcare level, and there the linkages with communities themselves. A lot of the reforms we're talking about is how to make our very Ministry of Health, what are workers' rights? We think of the health sector, but the communities themselves have a very vital role in creating a safe environment for health workers, building a relationship of trust and mutual understanding. And that engagement, these are things the health sector already should be doing. We have village health committees, we have clinic committees. So sometimes it's not creating additional siloed interventions. It's looking at how can we strengthen the relationships in the health sector at that frontline level to create better understanding and responsiveness to develop those solutions. And communities are also a key partner in this. Thank you.
Absolutely. Thanks, Asha. Michelle, final thoughts.
Yeah, so I think my final thought is something that I'm just noticing hasn't really come up as in the podcast and other spaces, is really the importance of legal frameworks in this space, right? So ensuring that, that this isn't left to only the organization to address or left to only that there's actually strong legal frameworks that are in place that can really address some of these issues. And that's something you'll see teased through in all of the frameworks that I've referred to. ILO Convention 190 talks about the enshrining this in legal. The CARE Compact also talks about needing to have national and subnational laws in place. So not just strategy and policies, but laws in place. And the respect framework also alludes to the importance of the legal framework. So I think it's really important to take this seriously and ensure that there's strong red lines in place that are held as well.
Absolutely. And thanks, Michelle. And thank you again to both you and Asha for taking time and discussing these issues with us. And thank you for our listeners for listening. Do join us for the next episode of Touchpoint. Thank you.